this was a fairly recent study that then said if someone's hospitalized for COPD, does their FEV1, does their spirometry value predict who's likely to do poorly over time? And it turns out that as you go from moderate to very severe disease, the risk of you dying over a 3-year period goes from 1 in 10 to about 1 in 4. I'm not saying this stuff to scare you, but it's this information that is causing the paradigm shift in the way we treat COPD. What it's forcing us to do is to look at the patient who's hospitalized and say, at that hospitalization, what are we going to do to mitigate the illness? If we leave things unchecked, this is the potential course. 1 in 4 chance of dying in a 3-year period. So this is where, what's the old expression, we need to get busy as a doctor. We need to get our patients on the right medicine, get them with the right therapies, get them into rehab, whatever it takes, so that we avoid this and we go back to this course. Next slide. So a group that I know up in Mass General, up in Boston, said, well, maybe the FEV1's not enough because we have a lot of patients who have abnormal spirometry, and some of them do great, and some of them are sick as can be. And even with your group, I heard some of you saying, yeah, I have COPD, but it really doesn't affect me like it affects others. So maybe there's more to the story than spirometry. So what they looked at was your spirometry. But they also said, well, what is your endurance? People who are weak and can't do for themselves are more vulnerable than people who are independent. So they use that as a factor. They use something called a 6-minute walk. Some of you may have had that done in rehab. So they walk you at your own pace for 6 minutes. That's what they're looking for. Then they looked at something called the MMRC. It's a British scale of how short of breath you are. So some people look short of breath and you say, are you okay? And you're like, I'm fine. And other people look fine and they're like, I can't catch my wind. Their sensation of dyspnea tells you how ill they are. Dyspnea is how short of breath you are. And then they look at your body habits. Are you becoming very thin and wasted? Are you getting swollen and robust? And then they came up with a scoring system. And this was done by Bart Shelley and his group. And he was pushing for this for over 10 years, and it just never caught on. But then he got it published back in 2004. Next slide. And lo and behold, what he found was, this was your typical slide where as your lung disease goes from mild, moderate to severe, your risk of death is higher. But then if you use the other variables, body weight and shortness of breath, it was able to separate these groups more definitively. It gave you more information of what's going on in that individual patient. So more information was better than less. Now, unfortunately, it's a cumbersome system, so it's not used readily. They use it in research studies, they use it at transplant centers, but they don't use it routinely because it's a little bit cumbersome to calculate. Next slide. So why am I telling you all this? We're all the same era, right? None of us are spring chickens anymore. If we did things the way we did them 30 years ago, look how backwards we would be. So a phone is a phone is a phone. But look at what's happened in just 30 years. My children have never seen a rotary phone. They have no idea what this is. My medical students have never seen this. But this is what we grew up with. So when I meet with young physicians, I tell them, you've got to look at the future. We know what the past has established for us. We know the natural history of the disease. We know the pattern of the disease. What is the future going to bring us? And I can tell you, in a few years, we won't even be using phones like this. We're going to have devices clipped to our ties or on our wrist or on our glasses. The technology is advancing very quickly. Next slide. So what are the changing paradigms? How are we looking at the disease differently? Well, the first is reminding everyone, this is not one disease. So when someone says, I have COPD, you have to try to pinpoint. Is it with sputum or without? Is it with bronchiectasis or without? Are you gaining weight or losing weight? It makes a difference in how we manage it. Next slide. There are different pathologies. The thing that causes bronchitis is different than the thing that causes bronchiectasis. Next slide. There are different phenotypes, and I'll go over that in a little bit. And that we can use the phenotypes to tailor-made therapies. And isn't that what you guys want? How often do you feel like you're going to the shoe store and they're offering you just one pair of shoes? Everyone who comes in with a cough is getting the same therapy. Wouldn't you want something tailored for your needs? the benefits of modern therapies, the benefits of the non-pharmacologic therapies, like rehab, or some of you have talked about bronchial thermoplasty in asthma, or volume reduction surgery in emphysema, or transplant in chronic lung disease. These unusual therapies, when is it appropriate and when isn't it? It's really based on your phenotype. Next slide. So what do I mean by phenotype? Phenotype is the attribute that describes the differences in patients with the same process. In other words, we all have eyes. I have blue eyes, some people have brown eyes. That's a phenotype. We all have hair, or in my case, had hair. And at one time it was long and red. Some of you have blonde hair, some of you are brunette. These are phenotypes. They're descriptors. So how do we use it in lung disease? Next slide. So we have clinical parameters. We have physiologic parameters. We have radiologic parameters. And we have biomarkers. And I'm going to go over all of those. This is really cutting edge stuff, guys. This is just in the last few years. And a lot of it is based on some very large studies looking at COPD, where after they completed these studies looking at thousands of patients, they said, well, let's just break it apart. How many of them had just emphysema? How many of them had chronic asthma? How many of them had bronchitis? And how did it affect? So these are the subpopulations that they looked at, and we gleaned a lot of information. So what about the clinical parameters? So the clinical parameters are what the patients tell you. Do you have a chronic cough? I'm hearing a cough. And that is a bronchitic cough, just from the tone of it, from the texture of it. I can tell you that that's chronic bronchitis as part of the cough. There are high-pitched coughs. They call it a barking cough. That's laryngeal coughs. That's not from the airways. That's from the voice pouches. So the character of the symptom of the cough makes a difference. The frequency of exacerbations. Patients who say, you know what, I seem to carry a cold every 6 or 8 weeks. I get sick 5 or 6 times a year. Their disease course is very different than someone with chronic lung disease who has shortness of breath, but they've never been to a hospital or an emergency. And then there are inflammatory markers that we look at. Physiologic parameters. Spirometry is the gold standard. How much can you get in? How much you blow out? It's adjusted for your size, for your age, for your sex. We make the adjustments for that because the mechanics of breathing are affected by our body shape, isn't it? So I saw a gentleman yesterday where they did all these calculations, that he's a fairly short man in his legs with a very long torso. He was a baseball player when he was young. So his thoracic capacity was greater than expected because they adjusted for his total size and not for his shape. People who, unfortunately in our age, we put on a little weight in our center. The bigger the weight in the center, the smaller our lung volumes because the abdominal contents affect our mechanics of breathing. So we adjust spirometry based on those findings. There's a phenomenon called dynamic hyperinflation. How many of you with emphysema, so it's really not for fibrotic lung disease, but with emphysema, how many of you have had the experience where as you're walking you get a little more shorter breath, and then the harder you breathe, the harder it is to breathe, and then all of a sudden you just have to stop, grab a chair, and lean forward and catch your breath? Has that happened to any of you?
Oh, yeah.
That's called dynamic hyperinflation. You're able to get air in, you're not able to expel it. And the harder you're getting air in, the less you're expelling, and the lung gets bigger and bigger and bigger and bigger and bigger, and pretty soon you just can't catch your breath, and you lean forward, and it feels bad. This has been demonstrated in studies going back 15 or 20 years, but now they're looking at it in terms of what specific therapies fix this problem. Because if you can fix that problem, your exercise tolerance gets better, which means you can walk more with less energy. And that's looking at the exercise part of it. And then radiologic criteria. We went from tomograms and x-rays to CAT scanners, to high-resolution CAT scanners, to multi-gated CAT scanners. The imaging is so pristine now, it reminds me of when I was a student looking at the exposed chest in the operating room. That's the type of detail we can get from modern imaging. And there are nuances in it that tell us about the type of disease. We can see with discretion things as small as the head of an eraser using CAT scanners. So let's talk about basic descriptors. You look around the room, and this is actually drawings from an artist named Frank Netter. And Frank Netter drew diseases for a catalog called the See the Guy Catalog in the 70s, and before actually. Let's look at the first slide. He described emphysema as the pink puffer. The man is leaning forward, who's lost body weight, his ribs are showing because he's lost muscle, and yet he has emphysema, he's short of breath, COPD, compared to the chronic bronchitic, and he called him the blue bloater. The chronic bronchitic actually is gaining weight, a lot of it is fluid weight. They're hypoxic, they're dusky, they're blue, and they have a chronic cough. So a big picture of a thing that cup to expectorate. So even back then, he knew that COPD had at least two different descriptors. Someone who could be wasting and someone who could be normal. And this is from Barcelli at Mass General. These were two of his patients with the same spirometry. So when they measured their lung function, it was the same. And yet you had someone who's wasted and someone who's edematous swollen. And yet it's the same diagnosis, COPD. All of you would agree that this is not the same disease, is it? It's affecting these gentlemen differently. That's what we're trying to teach our students to look at. Next slide. What about the clinical pattern of the disease? The gold criteria came up with three criteria. We said there's the exacerbator, someone who has frequent episodes of bronchitis. Then there's asthmatic bronchitis, someone who has predominantly an asthma disease, they feel better when treated, but it flares frequently. And then pure emphysema. Next slide. And it turns out, the more you have exacerbations, the worse it is in terms of your quality of life, the worse it is in terms of the progression of your lung disease, the worse it is from a healthcare management point of view. It costs a lot of money to take care of people when they're sick. It has a signal for increased mortality. So this is a group more likely to have morbidity and mortality than others. And we do know from spirometry that they lose function faster than a non-exacerbator. I have had some patients I've been following for 20 years. Their lung function now is about the same as it was in 1995. I have other patients where in 3 years' time, they've gone from active to less active to homebound in just 36 months. This phenotype is something that we need to look at more closely. What about biomarkers? My research colleagues downtown at VCU are very excited about this. Wouldn't it be nice if there was a blood test that would tell you you're at risk or you're not at risk for progressive lung disease? Next slide. So they're looking at exhaled markers, serum markers, sputum markers. They have a whole host of them they're looking at. None of them have been validated yet, but I can guarantee you in a fairly short period of time, we will have markers, biomarkers, that your doctors can use to help screen you to identify what therapies will be good for you. And let's talk about the imaging. We have the advanced chest CT, we have MRI, we have nuclear medicine. There are all sorts of things that radiology is able to do, and I'm going to show you some examples. I'm not going to expect you to become radiologists after this. So let's start with something as simple as asthma. And I'm using this because even though it's a blurry image, this is a fairly normal x-ray. The heart in the center, right lung and left lung. And the only thing you're seeing on this x-ray is a bronchial tube on end that's thickened. So on an image, the bronchial tube should look like ceramic. It should be wafer thin. And a bronchial tube that's swollen and thickened is very common with chronic asthma. Next slide. Now this is chronic bronchitis. So in addition to having some peribronchial thickening, there are some chronic scarrings in the lung. There's distortion of the windpipe, that's called a saber-tooth deformity. And while it doesn't show up in the room, there's a pattern called a mosaic pattern. Part of the lung is inflated, part of it's less inflated, and it has to do with the